program organized by the College of Specialists in Rheumatology and Rehabilitation, Sri Lanka. Today we have two interesting presentations. First presentation by Dr. Dilrukshi Tennakone, Consultant Rheumatologist and Rehabilitation, BGH Gampaha. She will be delivered on cascading events of vasculitis. Over to you, Dilrukshi.
Good afternoon, ladies and gentlemen. Thank you, Paritha, for that introduction. And I would like to thank the college for giving me this opportunity to present to you. So for this month's CME, I'll be presenting to you a lady. She's a 41-year-old female, a mother of 4 children. She presented in the early days of October last year with a history of low-grade fever for 3 days, but on admission, she was afebrile. She complained of arthralgia, myalgia, fatigue, and heaviness and paresthesia of her legs. Quite normal aches and pains without anything very significant, but she insisted on admission with the above symptoms that the medical officer in the OPD had to admit her. On examination, she was well-built, afebrile, but had a low mood. She did not have any tender or swollen joints. There was no clinical evidence of arthritis, even though she had a lot of arthralgia and myalgia. There was no muscle tenderness or weakness that was elicited. Rest of the system examination, including the cardiovascular, respiratory, abdominal, and nervous system, was normal. There was no lymphadenopathy. In particular, she was continuously complaining of paresthesia and heaviness of her lower limbs. The neurology, motor was normal, but she was complaining of these sensory symptoms. So she got admitted to a medical ward, and they have organized baseline investigations. The ESR was 32, nothing very significant. Liver function tests, renal function tests were normal. The UFR, however, showed 1+ of albumin and 25 to 30 red blood cells. Because she was complaining of myalgia, CPK had been arranged, and that was also within normal limits. When the full blood count results came, it showed increased WBC count. It was 18,000. Neutrophils 58%, lymphocytes 20%, and the eosinophils were elevated at 16%. The hemoglobin was normal, within normal limits. Platelets were slightly elevated. So with this, they had gone on to arrange for a blood picture. Well, the blood picture showed leukocytosis with severe eosinophilia, and the neutrophils showed toxic changes. Red cells and platelets were normal. In the comments, they had documented infection or inflammation as the cause for this blood picture and were the severe eosinophilia due to very reactive, allergic, parasitic, or inflammatory causes. With this history, the patient was questioned. She gave the history of asthma, but there was no rhinosinusitis. They had conducted a sinus view X-ray, which looked quite normal. The chest X-ray also did not show any gross abnormality. So when we consider hypereosinophilia, that is what this patient had, we have to consider small vessel vasculitis like GPA, microscopic polyangiitis. I'm sorry, I have not included the EGPA. So eosinophilic granulomatous polyangiitis. Then we have IgA and cryoglobulinemia as well. But to differentiate, they have immune deposits. And this hypereosinophilia could be due to eosinophilic disorder. The causes are allergies, hematological conditions like parasitic infections, hypersensitivity disorder, and other causes could be HIV and IgG4 related disease. So with this in mind, the medical team had arranged further investigations, which were quite unremarkable. This ultrasound scan abdomen was normal, septic screening negative, blood culture, urine culture, all sterile, stool full report normal, hepatitis C antibody, B surface antigens negative, HIV 1 and 2 were all negative. She was treated symptomatically with analgesics, antiworm treatment, and as was suggested in the blood picture DEC, she was having low mood, psychiatric referral for low mood. She was started on antidepressant medication. Then, while in ward, the patient developed an arthritis of small joints, mainly of small joints of the hands. The rheumatoid factor theta was 47. The lower limit is 11. ANA was negative. Then she developed a palpable purpura over lower extremities, and this was sent for biopsy. This is what the lower limbs looked like. She had in the thighs and the whole of the lower extremities. Her full blood count was monitored, so she was admitted on the 10th. If you go up to the 16th here, you will see that the WBC is elevated. You have the eosinophils increasing further as you go on. And here it is almost 50% of the total white cell count. The platelets again, there's increased probably due to reactive disease. ESR is 32, CRP was initially 16, later on it went up to 52. When she presented to the medical ward, she was continuously complaining of paresthesia of the lower limbs and heaviness, and with a background of hypereosinophilia, because EGPA or eosinophilic granulomatous polyangiitis was high in the differential diagnosis. They planned for ANCA studies. So C-ANCA and P-ANCA were both performed. You can see that C-ANCA is negative, whereas the P-ANCA is positive at a very high titer. The normal is less than 20. You see that in this patient, it is more than 200. Along with that, because of the lower limb symptoms, it was planned to perform nerve conduction studies, EMG, in her lower limb, in her limbs, and this is what it showed. You will see that in both the right and left, there's no recording in the tibial nerves, the common peroneal nerve, Sural nerve in both left and right, there's no recording. So the findings are consistent with mononeuritis multiplex predominantly affecting the lower limbs. So we had a lady who presented with very vague symptoms of arthralgia, myalgia, and complaining of heaviness of lower limbs, evolving. This, mind you, this is within one week or 10 days maximum. The disease is evolving very rapidly, rapid increase in the eosinophil count, and we see the patient developing arthritis, developing vasculitic rash. And the investigations show mononeuritis multiplex. The skin biopsy report was also available at that time, which showed leukocytoclastic vasculitis with eosinophilic infiltrates. So this patient had blood eosinophilia, which was severe, P-ANCA positivity, mononeuritis multiplex, with a background history of asthma, and she was diagnosed with eosinophilic granulomatosis with polyangiitis. So we plan to start her on IV methylprednisolone at a dose of 1 gram daily pulse therapy. But unfortunately, at that time, IV methylprednisolone was not available. It was not available in the government sector as well as in the private sector. So we started her on high-dose oral steroids, prednisolone at a dose of 1 milligram per kg per day. Her purpura responded to this, but minimal improvement of the lower limb symptoms. There was a plan to combine this with IV rituximab for induction of remission. Cardiac screening showed normal cardiac functions. While we were preparing her for IV rituximab, she developed one bout of profuse diarrhea. Settled, we were thinking of, again, gastric involvement. With this, she received the IV rituximab 1 gram infusion, no adverse events, and the patient was clinically responding. She's a mother of 4. She wanted to go home. She was discharged home on 60 milligrams of oral prednisolone daily with a plan to readmit for the second infusion in 2 weeks. After 2 weeks, she was readmitted. She was complaining of generalized body aches, arthralgia, myalgia. According to the husband, she had been well during the 2 weeks that she was at home prior to the readmission. On the day, the evening prior to readmission, she had been a little pensive and anxious looking. And the husband thought it is because she had to come to the hospital for an infusion. On admission, she had these symptoms. There was chest discomfort and she was complaining of difficulty in breathing. She was found to be having tachycardia and tachypnea. Urgent ECGs, arterial blood gases, and troponin was sent. Cardiac involvement, pulmonary embolism were differential diagnosis at this moment. At the same time, she was found to have high blood sugar. She was started on soluble insulin. The ECG showed sinus tachycardia. There were no ischemic changes. Arterial blood gas analysis showed respiratory alkalosis. She was managed in the ICU from here onwards. Her heart rate was 115, blood pressure was high. However, she maintained 100% saturation on air. Respiratory rate was increased. Capillary blood sugars again were elevated, which was managed with insulin. So at this moment, the question was, is there an acute coronary event? Anti-anginal medication as well as subcutaneous enoxaparin was started, and a 2D echo was performed, which showed a thin rim of pericardial effusion, but with normal left ventricular functions. Again, she developed a bout of profuse diarrhea, but there was no bleeding. While in the ICU, she was treated with IV meropenem, the enoxaparin, creating a pulmonary embolism. The troponin I returned, it was quite elevated at 30, whereas the cutoff level would be less than 0.1. Repeat 2D echo was performed at this point, which showed hypokinetic apex, anterior wall, and the septum, and the ejection fraction at this moment was 35 to 40%. So we see a patient who is very rapidly deteriorating, very rapidly evolving with her vasculitis. Again, the repeat ECGs did not show any ischemic changes. The echo findings they have mentioned is as LV dysfunction, probably secondary to myocarditis. She also complained of lower abdominal pain and tenderness. The iris was normal. Chest X-ray did not show any gas under the diaphragm. So at this moment, we decided against IV rituximab. She was clinically unstable. Infection risk was also there. Procalcitonin was within normal limits. Because we decided not to go ahead with the IV rituximab, we planned for IV methylprednisolone pulse therapy. Fortunately, we were able to get hold of a few vials from the private sector, and we were about to start this. However, unfortunately, while in the ICU, she developed a cardiorespiratory arrest, unrecordable BP, and she could not be resuscitated. So we see a lady who has presented to us with very vague symptoms and evolving very rapidly due to the vasculitis that she is having. So let us see what eosinophilic granulomatosis with polyangiitis is. It was called Church-Strauss syndrome. It is very rare. It says that the incidence is around 1 in 100,000. It affects small to medium-sized vessels, and it is an ANCA-associated vasculitis. Clinically, you have associated asthma, blood, and tissue eosinophilia as hallmarks. Histologically, there'll be tissue eosinophilia, necrotizing vasculitis, and eosinophil-rich granulomatous inflammation. The male to female ratio is, some say it is comparable between male and female. Some say there's a slight male preponderance. The mean age of presentation is around 50, but the symptom onset could be around 38. And they talk about 3 phases of prodrome or allergic phase, where you have the asthma and rhinosinusitis, which could predate the second phase by a few years, even 3 to 10 years. Then comes the eosinophilic phase, eosinophilia and end organ involvement, and the vasculitic phase with small vessel vasculitis. It is heterogeneous in clinical phenotype. The MPO or P-ANCA could be detectable in around 40% of patients. Asthma is found in 90%, as I said earlier, ENT involvement, nasal polyps, rhinosinusitis in about 60 to 80% of patients. Eosinophilia, more than 10% or more than 1,500 per microliter is seen. There could be lung infiltrates in about 40 to 50%, which could be multiple and migratory. Peripheral neuropathy is seen in 50 to 70%, especially mononeuritis multiplex. Skin lesions, you can have palpable purpura. Myocarditis, pericarditis, gastroenteritis, and renal disease are all known presenting manifestations. Fatigue, loss of weight, myalgia, and arthralgia could also occur. So we see most of the, we see that P-ANCA could be positive in around 40% of patients. And in the clinical spectrum, ANCA positivity and negativity could give rise to certain different symptomatology. You will see in ANCA positive as well as ANCA negative patients, eosinophilia, chronic sinusitis and nasal polyps, asthma, commonly seen in both ANCA positive and negative patients. In ANCA positive patients, you see glomerulonephritis, peripheral neuropathy, and purpura commonly, whereas gastroenteritis, cardiomyopathy, and lung infiltrates are more commonly seen with ANCA negative patients. So in our patient, we had both these symptoms that are seen with ANCA positivity as well as negativity. So the immune pathogenesis, if you talk about the immune pathogenesis, is eosinophil-mediated tissue damage. We can have the T cell involvement, the T helper 1, T helper 1s, and 17 in vasculitis and granuloma formation, and there's dysregulation of the humoral and B cell responses. Now, this is depicted in this diagram. You will see here, we have the eosinophilic inflammation as well as the ANCA-mediated inflammation. So here, ANCA is responsible for the pathophysiology as well. So a person having genetic predisposition being exposed to chemical agents, drugs, infection, inhalant agents, antigens will give rise to this cascade of events. You will see eosinophilic inflammation gives rise to interleukin-5 release, which gives rise to the gastroenteritis, cardiomyopathy. Sorry. And in the ANCA-mediated inflammation, we have the B cells. There's glomerulonephritis, necrotizing vasculitis, and in the combination, in the overlap of these two immune pathological pathways, you see asthma, alveolar hemorrhage, systemic pneumonia, and mononeuritis. So we talk about classification criteria now. Diagnosis is, we don't have diagnostic criteria. When we talk about classification criteria that we use to classify these patients. Sorry if this is not very clear. So in 1990, we see the first set of classification criteria endorsed by the ACR. So these are the 1990 ACR criteria for the diagnosis of Church-Strauss syndrome, asthma, eosinophilia more than 10% in the peripheral blood, paranasal sinusitis, pulmonary infiltrates, histological proof of vasculitis with extravascular eosinophilia, mononeuritis multiplex, or polyneuropathy. If you have 4 or more criteria, then a diagnosis could be made of Church-Strauss syndrome. That was what was accepted in 1990. Then we have, moving on, we see the 1993, the first Chapel Hill Consensus Conference provided nomenclature for systemic vasculitis. Then we moved on, and the second, in 2012, we had the second Chapel Hill Consensus Conference introducing revised nomenclature of systemic vasculitis. And here they have included ANCA as a surrogate marker of vasculitis. More recently, in 2022, the ACR, there's a classification criteria based on the DCBAS, that is the Diagnosis and Classification Criteria in Vasculitis Study, which has been endorsed by the ACR and EULA. So according to this classification criteria, it is a weighted criteria. So it should be applied to classify a patient having eosinophilic granulomatosis with polyangiitis when the diagnosis of small or medium vessel vasculitis has been made. We have clinical criteria as well as laboratory and biopsy criteria. We have positive criteria as well as negative criteria. You will see this here. So in the clinical criteria, obstructive airway disease carries 3 marks. Nasal polyp, again 3 marks. Mononeuritis multiplex will carry 1 mark. Lab and biopsy criteria: blood eosinophil count more than 1 into 10 to the power 9 per liter will have a very high mark of 5. Extravascular eosinophilic predominant inflammation on biopsy will carry 2 marks. At the same time, if the patient is positive for C anchor, a negative mark is given, -3. And if the patient has hematuria, it is -5, because these are more commonly seen with granulomatous polyangiitis rather than eosinophilic granulomatous polyangiitis. So you sum up these scores, and if the score is 6 or more, then a diagnosis of EGPA can be made. And here they have given a sensitivity of 85% with this criteria and a specificity of 99%. If we briefly talk about the treatment options we have for treating a patient with EGPA, the remission induction is tailored on clinical manifestations with prognostic relevance. Here they have considered 5-factor score, or FFS, to be considered when choosing remission induction. This predicts the risk of mortality. Anchor status also could have a prognostic implication. Overall survival is worse in negative, probably due to the cardiac involvements, and the relapses are more commonly seen with anchor-positive disease. Now, when we consider the 5-factor score, what is the 5-factor score? It's renal insufficiency, proteinuria, cardiomyopathy, gastrointestinal tract involvement, central nervous system involvement. So if these are there, the prognosis is worse. This original 5-factor score is modified lately to include age more than 65, and the central nervous system involvement has been taken off. And here they have also mentioned that ENT involvement is a favorable prognostic factor. When we talk about treatment, even though the patient did not have certain manifestations at the onset of treatment, appearance of new manifestations on follow-up should be considered for disease flare treatment. So for remission induction, severe disease, pulsed IV glucocorticoids, IV methylprednisolone, either 500 or 1 gram for 3 days. High-dose oral glucocorticoids, prednisolone at a dose of 0.75 to 1 milligram per kg per day. Then for remission induction, cyclophosphamide, some have mentioned 12 pulses, some say 6 pulses, every 2 weeks for 1 month, then every 4 weeks at 0.6 grams per square meter or 500 milligrams per square meter. Then we have IV rituximab, and lately some mention this for remission induction, some for maintenance. The anti-IL-5 agents, mepolizumab and ozolizumab, could be used in the treatment. So maintenance therapy could be with rituximab or with the conventional immune suppressants like azathioprine, methotrexate, or mycophenolate mofetil. Here you will see where the new onset active EGPA patients would be categorized according to their symptoms into severe and non-severe. If there's 5-factor score is more than 1, or there's presence of peripheral neuropathy, alveolar hemorrhage, or other organ or life-threatening manifestations, here they have included mononeuritis multiplex as well. Then it is taken as severe, and their remission induction is by IV pulse followed by high-dose oral glucocorticoids, cyclophosphamide or rituximab, and for maintenance of remission with glucocorticoid plus or minus rituximab or mepolizumab and the other conventional immune suppressants. If it is non-severe, then where the 5-factor score is 0, or there's absence of peripheral neuropathy, alveolar hemorrhage, or other organ or life-threatening manifestations, then glucocorticoid alone would be sufficient. And for maintenance, only glucocorticoids or mepolizumab. If there's relapse, then we have to stratify whether it's severe and non-severe accordingly. If it is severe, treat with IV pulse, high-dose IV glucocorticoids, followed by cyclophosphamide or rituximab. So we discussed today a patient, a female, who presented with very vague symptoms, and this is less than 1 month of history, evolving into a full-blown eosinophilic granulomatous polyangiitis, and unfortunately succumbed to the severity of the illness. So I hope you've learned something about this very rare condition. And last, I would like to acknowledge and thank the consultant physician at District General Hospital, Gampaha, Dr. Charit Kumar, for getting us involved in the care of this patient. Thank you.
Thank you for requesting informative presentation. Any questions? I hope Fred is there. Yeah, there will be multiple questions from Dilrukshi.
Thank you very much. I use site. You have seen that. You have seen quick die. But you have done different.
Yes, a very difficult situation. So whether we could have, somehow tried to give her the IV methylprednisolone, whether that would have made a difference, but then IV as well as oral, they say they have comparable efficacy. Whether we should have thought about now, they talk about 2 regimes of rituximab. You can give 500 milligrams weekly, go for 4 weeks, and 1 gram 2 weekly. But it has the same efficacy again, but with the severity and the speed at which she was developing, whether we should have maybe, given the second dose of 500, whether we should have given that. That is something, thinking back, we consider whether we should have done that. Maybe on the other hand, should we have, I think we from the onset, when we thought about mononeuritis multiplex with the hyper-eosinophilia, this much high eosinophilia, we were considering EGPA. So whether, confirmatory investigations, whether we should wait for the confirmatory investigations or start treatment, but that's again debatable. It was not available at that point. Actually, when she developed the second readmission, when she came with the cardiac features, the cardiologist was actually saying, could it be due to rituximab? And, that's one of the reasons why we did not go ahead with the rituximab. We were planning whether, give the IV methylpred and then subsequently to cyclophosphamide. I think I consulted her as well on this. Yeah, she had 4 children. Yes, we did not have cyclophosphamide at that moment. No, not available. Not even IV methylprednisolone was not available. We were trying to get it down. Not even available in the private sector.
I think the decision shows when the participant fine creating the needed and so on and is fine in some situations because I don't think that malaria can have this point of view of the other systemic symptoms. If you have a more systemic symptoms, okay, it's right. But I think the decision would be to refer to the rheumatologist as soon as possible. When you get the patient like this.
It was mentioned that, probably because of the diagnosis that was given to her, complications due to this, but no histological evidence was available. Yes, yes, ma'am. And actually, the second admission itself, the first echo did not show any dysfunction in the left ventricular functions. It was now within normal limits, and the second one only the next day. It was the second admission was actually 2 days. Was admitted the next day by noon. She had the arrest. Oral. DEXA. Yes, that's something to consider, I think. She probably, I mean, the absorption would have been all right. I mean, she had very high blood sugars when she came for the second readmission. So probably the prednisolone absorption would not have been that erratic. But yes, that's something maybe we could have, going back, yes. Yes, yes. Yes, with the first dose of rituximab, there was a good response and she wanted to go home. Yes, without somewhere it was mentioned as 25% 5-year survival. Yes, 5-year survival without treatment is 25%. I'm not sure. Yes. So anyway, it's a very bad, poor prognosis, especially because this was evolving very rapidly. But thinking back, there were many places where we thought whether we could have done differently to change the outcome.
Thank you, Dilrukshi. Actually, we cannot discuss after the case, there are a lot of options. But in managing patient, really bored. We can't get investigation. We can't get the full blood count, even UFR, even ANCA takes time. So very difficult to manage a real case in real our setup. So what we can discuss in this forum, but when managing patients, they're really difficulty, especially they can't afford for the big investigation, even they can't do outside UFR sometimes. Right. Okay. Our next presentation will be on unveiling the butterflies and wolves on the skin. Dr. Nadeera Lokuhapuarachchi, Senior Registrar in Rheumatology and Rehabilitation, NHSL. Over to you, Nadeera.
Good afternoon to all of you. And first of all, let me thank the College of NHSL for providing me this opportunity today to present here. And in this presentation, I will be taking you through for unveiling the butterflies and wolves on skin. And first, I will be presenting 3 histories. Case 1 is a 51-year-old female diagnosed with SLE with a vasculitis crash. She was asymptomatic with the treatment with HCQ and azathioprine for 6 months. After 6 months, she presents with tender nodular skin lesions on abdomen, which gradually ulcerated. And later, she developed similar nodules in proximal arms and thighs. And there was proximal muscle weakness and dysphagia as well. And in these photos, you might be able to see those nodular lesions. And investigations-wise, the CPK was high, muscle biopsy revealed myositis, and the ENA panel was negative, and biopsy came as panniculitis. So she was diagnosed as having lupus profundus with lupus myositis. And she was treated with methylprednisolone pulses and cyclophosphamide due to the severe myositis and dysphagia. The muscle weakness improved and the CPK also came down with treatment, but the skin lesions were resistant to treatment initially. But it also responded when MMF was started. In the second case, again, we have a 20-year-old girl with SLE. She was on HCQ and low-dose oral prednisolone. She presented with a diffuse acute onset mucocutaneous ulcers with desquamation of the skin. And she had a history of being treated for a febrile illness with antibiotics for a period of 1 week. And in this picture, you might be able to appreciate the extensive involvement of the skin and mucous membranes with desquamation. The lesions were extending into the salts as well. And the first thought was whether this is Stevens-Johnson syndrome due to antibiotics. But she had worsening of symptoms despite stopping all the culprit agents. And with high inflammatory markers, the dermatology team suggested this is toxic epidermal necrolysis like acute cutaneous lupus erythematosus. And she was again treated with systemic steroids and HCQ, for which she responded well. In the third case, a 17-year-old schoolgirl, she was diagnosed with SLE and class 2 lupus nephritis 2 months back. She had maculopapular skin lesions on face, ears, and scalp, suggestive of discoid lupus. She was on HCQ, oral prednisolone, and MMF. However, she had poor compliance to treatment. And 5 months later, she came back with worsening of the skin rash, and the treatment had to escalate with high-dose steroids and MMF 1 gram BD. In the next visit, the lesions were progressive, ulcerative, and the first picture shows the abdomen and the umbilical region, and the next one, her back. The lesions were progressive, and there was poor compliance to MMF. With the inputs from the dermatology team, she was managed for a severe cutaneous lupus flare, which involved more than 18% of the body surface area, after exploring other differential diagnoses, including infections like HSV and Staph aureus. She was pulsed with methylprednisolone followed by high doses of oral prednisolone, and she was on HCQ and MMF. Local applications were provided for the ulcers. And still, she did not respond well to this treatment, and new lesions were appearing with erythematous, painful, non-blanching maculopapular lesions in the palms and soles, suggestive of possible vasculitic rashes. So the treatment was escalated to IV cyclophosphamide with GnRH agonist co-therapy, and skin lesions gradually improved with that. The skin biopsy revealed mild acanthosis and parakeratosis of epidermis. There was basal cell degeneration, no follicular plugging or basal membrane thickening. The perivascular and periatic cell inflammatory infiltration was mild, suggestive of subacute cutaneous lupus erythematosus. She had a remarkable response to this treatment, and she was on MMF 500 with HCQ and slow tapering of oral prednisone. But the story didn't stop here. Again, after 2 months, she was complaining of itching of the limbs, which progressed to develop tense blisters over the abdomen and limbs. And here, most of the blisters were ruptured, but you can see the base of those ulcers. She was diagnosed to have bullous lupus erythematosus and treated with Dapsone with a good response to treatment. So here we have seen 3 different patients with systemic lupus erythematosus presenting with various cutaneous manifestations. Lupus is the Latin word for the wolf, and initially it was the facial rash was resembling a wolf-like bite, and hence the name was given for this disease. And in the next part of my presentation, I will be taking you through the various cutaneous manifestations of lupus erythematosus. First, we will be looking at what is cutaneous lupus erythematosus, the pathophysiology behind that, the classification, association of cutaneous lupus with the systemic lupus erythematosus, the subtypes, the diagnosis and management. So, cutaneous lupus erythematosus is a rare inflammatory autoimmune skin disease. It can occur independently or with SLE. And as we know, SLE is a multisystemic disease. Cutaneous lupus is mainly involved in the skin and mucosa, as the name implies. Incidence is similar to SLE, and the peak age of onset would be in 3rd and 4th decades. It is rare in childhood, and again, it is more common in females. The prevalence and severity of the disease is more among darker skin types, and it has shown that the impact of cutaneous lupus on emotional well-being is greater compared to other dermatoses, maybe because of the pain, scarring, and disfiguring associated with this illness. Regarding the pathophysiology, there will be activation of the innate and adaptive immune system. And autoimmune response against the own epidermis will cause anti-epidermal inflammation and so-called interface dermatitis. There is an association with the major histocompatibility complex alleles and HLA association. And the inflammation may be driven by T helper cell 1, and it has shown that there's increase in IL-6 and IL-17 in these patients. The classification came in 2004, the Dusseldorf classification, classifying cutaneous lupus into 4 main categories. That is acute, subacute, chronic, and intermittent cutaneous lupus erythematosus. The chronic form further divided into discoid, chilblain, and lupus erythematosus profundus or panniculitis. Then we have to remember that sometimes there can be 2 or more cutaneous lupus subtypes can coexist in the same patient up to 30% of the times. They can develop non-specific skin lesions as well. And in subacute cutaneous lupus erythematosus, the anti-Rho positivity could be extending up to 80%. And if it is positive in acute cutaneous lupus, the patients are at a higher risk of photosensitivity. And cutaneous lupus can coexist with other autoimmune dermatoses like lichen planus or dermatomyositis as overlap syndromes. Among the subtypes of cutaneous lupus, DLE is the most common one. Then subacute cutaneous lupus followed by acute cutaneous lupus. And the DL is again more common among the African Americans, whereas the subacute cutaneous lupus, chilblain, and tuberous lupus are more prominent among Europeans. So what is the association of cutaneous lupus with SLE? Up to 80% of the SLE patients will develop cutaneous lupus during the course of their illness. And actually 25% of the SLE patients might present with cutaneous lupus as the first presentation. And the risk of progression into SLE differs. There's a different rates according to the subtypes of cutaneous lupus, whereas we have acute cutaneous lupus associated with SLE up to 90 to 100%. It is considered as one of the classification criteria in ACR. The subacute cutaneous lupus can progress into SLE up to 10 to 15%, and in chronic form, the DLE is associated 5% in the localized disease and 15% with generalized disease. Again, with the lupus profundus also, the progression into SLE might be up to 5%. Intermittent lupus or the tuberous has a negligible risk of progression into SLE. And they have found out that the presence of lesions below the neck and presence of nail coat lesions and periungual telangiectasias might increase the risk of progression into SLE. And the classification is gradually evolving. So let's move on to each types of the cutaneous lupus. First, we have the acute cutaneous lupus erythematosus, the classic central phase malar or butterfly rash, which is violaceous erythema, sparing the nasolabial folds. This is strongly associated with flares of SLE, and usually this is a transient rash which will resolve without scarring, but the telangiectasia may be persisting. Then we have a maculopapular rash resembling a mobiliform drug eruption. Then we have the lupus hair, the diffuse hair loss with non-scarring alopecia and brittle hair shaft. Photosensitivity is also another feature in the acute cutaneous lupus, where you have a range of presentation. It could be very mild or a very severe form with rash appearing after minimal light exposure. Then the mucosal erosions and ulcerations, mainly involving the lips, nose, mouth, and genitals, can be there. And as the sixth type, they can have bullous eruptions. There are mainly three types of presentations associated with lupus causing bullous eruptions. From that, the bullous lupus and like acute cutaneous lupus belongs to the acute cutaneous lupus erythematosus. They will be having blistering rashes, and especially with 10 like acute cutaneous lupus, there will be extensive mucosal and skin ulceration. Now let's have a deeper look into the bullous SLE. It is associated with antibodies against the type 7 collagen, which is there in the anchoring fibrils at the dermoepidermal junction. It is a rare disease, but it could be the first presentation in SLE up to 1/3 of the patients. There are three types, but they are indistinguishable clinically. And the usual sites involve the face and sometimes the mucosal membranes. The onset has no significant correlation with the activity of the systemic disease, and the bullae may contain a clear or hemorrhagic content. The blisters will heal without scarring or melia, but there can be pigmentation. And usually they will not have any further flares despite having systemic disease activity. The pruritus is usually absent or mild, and sometimes this could be associated with the flare of lupus nephritis. A diagnostic criteria was published in 1986, which included the presence of SLE, vesiculobullous lesions, and in histology showing subepidermal blisters with neutrophil predominant infiltrate and direct immunofluorescence having linear or granular deposits with IgG, IgM, or IgA. Then we have the subacute cutaneous lupus erythematosus, which is typically highly photosensitive, symmetrical, recurrent, and widely spread. It usually spares the face and hands and resolves with minimal scarring, but the dyspigmentation can persist. Up to 1/3 of the subacute cutaneous lupus could be due to drugs. This is characterized in histology by less dense infiltrate than DLE, but it is more compared to the acute cutaneous lupus. And there will be notable atrophy of the epithelium and vacuolation of the dermoepidermal junction. Sometimes this could be associated with the paraneoplastic syndrome. So, especially if the patient is presenting after the age of 60 years and not responding to the standard treatment or having other red flag features suggestive of malignancy, we have to look into that. There are mainly two forms of subacute cutaneous lupus. One is the papillosquamous type, resembling psoriasis or eczema, and the next one is annular subacute cutaneous lupus. Apart from that, there are two other rare variants of subacute cutaneous lupus. One is the erythrodermic lupus erythematosus, presenting as a generalized exfoliative erythroderma. And the next one is the lupus erythematosus gyratum remains with widely distributed chronic and recurrent figure-8 erythematous plaques as shown in this second photo. And with that, we will be moving on to the chronic cutaneous lupus erythematosus, again having 6 subtypes. There is discoid lupus erythematosus profundus or vasculitis, chilblain lupus erythematosus, varicose lupus erythematosus, vasculitis lupus erythematosus, and Rowell syndrome. So in discoid lupus, there are discoid erythematous and indurated plaques with follicular hyperplasia and hyperesthesia. The lesions are tightly adhering, and the manual removal will cause pain. And there are overlying scale extending into the hair follicles, which is also called as the follicular plugging. The active margin of the lesions will be there with central atrophic scarring and hypopigmentation. The commonest version is the localized type up to 80%, involving the face, scalp, and ears. And in the generalized DLE, the lesions would extend below the neck. They can have Hogner phenomenon, and sometimes on healed squamous cell carcinoma may be developed at later stages, and the patients might have high titers of ANA. In this picture, you will be able to see hypopigmented scarred areas with one lesion on the forearm and others involving the face. And here, a well circumscribed scarred earlobe, and then the scarring alopecia of DLE with follicular plugging. And the next one is the lupus erythematosus profundus or vasculitis, presenting as subcutaneous, nodular, or discoid, firm, deep, and tender infiltrations. There will be secondary adherence to overlying skin, and inflammatory erythema will be there. The most common sites are gluteal or hip areas, thighs, upper arms, face, and chest. Rarely, periorbital edema can be a presenting symptom of this type of the lupus, and ulceration and calcifications also can occur with the lesions. And you may find dents on the skin when the scarring and deep lipoatrophy takes place. Then we have the chilblain lupus erythematosus, usually presenting in the dorsal or marginal regions of the fingers, toe tips, ears, nose, or heels, where sites which are exposed to cold. And usually dsDNA will be negative in these patients, and there is a form called as familial chilblain lupus, which is associated with the monogenic inherited cutaneous lupus. Then we have some rare forms like verrucous or hypertrophic lupus erythematosus. It resembles keratoacanthoma and marked by the chronicity and absence of regression and resistance to treatment. The next type is the blasco-linear lupus erythematosus, again a rare subtype. Lesions appear as linear unilateral erythematous plaques following the Blaschko lines. These Blaschko lines represent the pathways of epidermal cell migration and proliferation during the fetal development. And the usual sites of these lesions would be face, neck, trunk, and extremities. but there will be no photosensitivity or association with SLE. And the sixth type is Rowell syndrome. Again, this could be a blistering lesion. Patients present with erythema multiforme like lesions with lupus erythematosus and characteristic immunological features. There's a diagnostic criteria which includes the presence of chronic cutaneous lupus, erythema multiforme like lesions, and positivity for ANA, anti-Rho or anti-LA antibodies, and having no causes like infectious or pharmacological triggers causing these symptoms. And the lesions are not usually appearing in the typical sites of where the erythema multiforme is occurring in other conditions, and the patients might be having other additional criteria for SLE. So the fourth type of cutaneous lupus is lupus erythematosus tumidus, or the intermittent cutaneous lupus, presenting as succulent, indurated, urticaria-like erythematous plaques, mainly in the photosensitive distribution in the exposed areas because of the high photosensitivity. They are smooth and there is no epidermal involvement, and usually they heal without scars or pigment disorders, but and they can have spontaneous remission as well. Apart from that, as I mentioned earlier, there's part of subacute cutaneous lupus erythematosus appearing due to various drug triggers. Up to about 25% of the time, these patients can present due to drug triggers causing some acute cutaneous lupus. And according to the literature, there are about 94 drugs associated, and commonly drugs like calcium channel blockers, beta blockers, ACE inhibitors, diuretics, TNF inhibitors, and antifungals are found with these. Most of the time, the progression of the disease will stop after stopping the culprit agent, but sometimes they also might need other treatment for the resolution. So, as we see, the presentation of cutaneous lupus erythematosus could be vast, and the differential diagnosis could be very huge. So we have to think about the possible other causes like infections, inflammatory autoimmune conditions, as well as malignancies. So how do we diagnose cutaneous lupus erythematosus? We need to go through the history, clinical manifestations, and the characteristic appearance of that. And there are no standardized diagnostic criteria for each subtype, and it can cause the diagnosis challenging. All the patients who are presenting with cutaneous lupus should have ANA tested and looked for other organ manifestations, because this can be associated with SLE. And skin biopsy is a valuable option to identify the subtype of cutaneous lupus. The histology in acute cutaneous lupus and in early lesions might be non-specific, but they will be more prominent when the lesions progress. And the biopsy should be usually obtained from an active non-treated lesion. And the active lesions will show interface dermatitis with anti-epidermal lymphocytic infiltration, vacuolations of the basal keratinocytes. There would be the cathosis, dermal infiltrations, and mucin deposits. And with direct immunofluorescence of uncertain cases, there might be deposits of complements IgG and IgM. And here is a comparison between the different historical features of cutaneous lupus. All of them share the same features, but to a different extent. The acute cutaneous lupus has the least amount of inflammatory infiltrate, basement membrane thickening, etc. Whereas in the chronic form, there will be degeneration of the basement membranes with the thickening of the basement membrane, significant perivascular and periadnexal inflammation with lymphocyte infiltration. And with bullous lupus, it is again that can have two types, including neutrophilic and the mononuclear variants. And in the discoid lupus, important features in the histology would be the involvement of hair follicles, then involvement of the upper and lower dermis, epidermal vacuolation, and apoptosis of the basal cells. and presence of dermal mucin, and sometimes when the inflammation subsides, there would be dermal fibrosis as well. In lupus profundus, there is prominent lobular paniculitis with fat necrosis, and sometimes eosinophilia could be there with vascular involvement. In lupus erythematosus tumidus, there is patchy lymphocytic infiltration, and the epidermis and subcutaneous tissues are usually spared. So how do we assess the disease activity and damage in cutaneous lupus? This tool was developed in 2005, Cutaneous Lupus Erythematosus Disease Area and Severity Index, which is mainly used in clinical trials and studies. And because of some limitations of that, it was revised again to include the rare subtypes of cutaneous lupus like lupus erythematosus tumidus and profundus. And now I will take you through the management of cutaneous lupus. This is a summary of the management. All of the patients should have lifestyle modifications, vitamin D supplementation, and consideration for the possibility of SLE and drug-induced cutaneous lupus. So what are the lifestyle modifications? Protection against UV and sunlight exposure is of utmost importance because the UV exposure will trigger cutaneous lupus, especially the tumidus and subacute cutaneous lupus. And it will also exacerbate systemic symptoms, including joint pains, fatigue, and reduced quality of life. And therefore, all the patients with cutaneous lupus should avoid unprotected outdoor activities, seek shade, wear protective clothing, and broad-brimmed hats. And they should avoid UV light treatment also. And they have to apply sunscreens with a very high SPF, ideally more than 50 or 60, applied in sufficient quantities 20 to 30 minutes prior to sun exposure. And factors like unclear advice from the clinicians, cost, tolerability, time constraints, and the various social norms would be limiting factors and barriers to achieve proper protection against this UV exposure. Apart from that, cessation of smoking is also needed because smoking is associated with increased disease severity and damage, and it also affects the efficacy of antimalarials as well. Apart from that, vitamin D3 should be supplemented because it has an immune modulator property with which has shown that the deficiency is a risk factor for cutaneous lupus as well as systemic lupus erythematosus. And the suggested daily intake is 1,000 to 2,000 international units. Then, in the localized and limited disease, we have options like topical corticosteroids, topical calcineurin inhibitors, and sometimes intralesional triamcinolone. This part of the disease is mainly managed by the dermatology team, and when this management is not sufficient or when there is disseminated or active disease, we might need to go to systemic treatment. HCQ is the only licensed treatment so far, but we are using many other off-label and empirical treatment in the management of cutaneous lupus as systemic treatment. The systemic treatment first line option is antimalarials, HCQ, used in all widespread and severe skin lesions. The dose is usually less than 5 milligrams per kilogram per day. And sometimes intermittent use of antimalarials are suggested, especially with photosensitive lupus or chilblain lupus. Apart from that, mepacrine can be used as an alternative first-line agent, especially when there's concerns about retinal toxicity. Quinaprine is used as an add-on therapy for refractory cases which are treated with HCQ monotherapy, and as a third-line option, chloroquine also can be used. With the use of these antimalarials, we have to keep in mind that acute hemolytic crisis could be there with P6PD deficiency. And all the patients who are on antimalarials should be having ophthalmological examination at baseline and annually after 5 years of treatment with HCQ or chloroquine. If the patients are having risk factors for retinopathy like pre-existing macular degeneration, renal insufficiency, or tamoxifen co-medication, or if the HCQ dose exceeding more than 5 milligrams per kilogram, they should undergo annual screening. And the American Academy of Ophthalmology has shown that treatment with HCQ less than 5 milligrams per kilogram per day for up to 10 years has low risk of HCQ associated retinal toxicity. Then again, we have systemic corticosteroids as first-line treatment in addition to antimalarials, especially with severe or widespread active cutaneous lupus or with systemic involvement. But the use should not be long-term, and the tapering off should be done because of the side effects. Then we have retinoids as second-line options, especially for hyperkeratotic lesions. The onset of action may take some time, but the issue is patients might get relapses following stopping the treatment. Then we have Dapsone again as a second-line option for refractory cutaneous lupus, but it is the treatment of choice. First-line treatment is bullous SLE. It will have a rapid response, which can be used as a feature of diagnosing bullous lupus, because other forms of bullous diseases might not have this much of rapid response. And the starting dose is a lower dose and gradually titrated according to the response. Again, we have to keep in mind about the hemolytic anemia, methemoglobinemia, and agranulocytosis, which could be there, especially during the first 3 months of treatment. DMARDs like methotrexate also plays a role in management of cutaneous lupus as a second-line agent. And if the patients are not responding or they develop GI side effects, we can try switching into subcutaneous preparations. Then drugs like thalidomide and lenalidomide are there as third-line treatment options, especially DLE showing high remission rates with thalidomide. But again, we have problems with side effects like neuropathy. And with lenalidomide, sometimes there is a concern that it might induce lupus erythematosus. For the lupus erythematosus profundus, these are not effective. MMF comes as a third-line treatment option for refractory cutaneous lupus, starting at a 500 milligram BD dose. And again, we can switch to enteric-coated mycophenolate sodium if patients are having GI side effects. Clofazimine, again, as a third-line treatment option, it is available, and it should be avoided with co-prescription with other antimalarials like HCQ, because the skin discoloration could be significant. And the monoclonal antibodies like belimumab could be there as third or fourth line of treatment. It is not recommended purely for cutaneous lupus, but with active SLE, this could be an option. And still there are no randomized clinical trials suggesting the use of it in cutaneous lupus per se. And rituximab also has insufficient evidence to support routine use in cutaneous lupus, but we can use it in patients with refractory cutaneous lupus because it has there are some evidence suggesting patients with SLE can get improvement with rituximab. Apart from that, cyclophosphamide, high-dose IVIG, and JAK inhibitors have also shown positive outcomes in case reports. And azathioprine and cyclosporine usually not used for cutaneous lupus without systemic involvement. And we have to be cautious against herbal supplements and traditional medicines, because it might contain steroids and sometimes they can exacerbate immune stimulation. This is suggested in the 2021 British Association of Dermatology guidelines. And the patients who are having Kobner phenomenon should try to avoid trauma, surgery, cryotherapy, and invasive treatment of the laser treatment of the skin unless unavoidable. As cutaneous lupus is a chronic relapsing disease, patients should be on proper follow-up, and at each visit, the disease activity, presence of skin and other organ damage, their quality of life, comorbidities, and presence of side effects for the treatment should be sought. And they advise to check and autoantibodies at regular intervals, probably 6 to 12 months, or at relapses to detect possible progression into SLE. And with that, The lupus is symbolized by the purple butterfly internationally, and usually the commonest or the most famous rash would be the butterfly rash, but it is not limited to the butterfly rash, and there are many variants as we have seen today. And the diagnosis and management would be challenging, and some of these lesions could be life-threatening as well. So we need to have a close communication with the dermatology team for the proper and timely diagnosis as well as in management. These are my references, and I would like to thank Dr. Gunitra Kasratna, consultant in rheumatology and rehabilitation in NHSL, Dr. Pudisana and Dr. Ramasinghe, consultant physicians, Dr. Janaka Karavita, consultant dermatologist, my colleagues, patients and their families for the support they have provided. Thank you.
A very informative presentation, cutaneous SLE. Any questions from the audience?
Patients ENA panel was negative, madam, and with the breakout list of lupus and the presence of lupus was more favoring the diagnosis of lupus myositis in this patient. A patient was having a nuclear pattern. Cytoplasm.
Low percent, less than 2%. So unfortunately, we can't do the myositis antibody. But if that ANA ET is very, very high, more than 1,000, 2,000, we are thinking about autoimmune polymyositis. So in that case, that is the diagnosis in US overlapping.
Yes, yes. But it will prevent the fibrosis probably in discoid lupus.
Okay, thank you very much for your kind attention. So our next program on 5th of April at ClinMark